Good morning, everyone. Ooh. I'm sure you can hear me, right? Good. I'm really happy to see the turnout that we have today. This is the 11th annual James E. Clyburn Lecture on Health Disparities in the United States. I'm proud to say that I was here for the first inaugural lecture. I see Sandra Glover there. I want to thank you right up front. Sandra is the most hardworking retired lady I think we have in South Carolina. So thank you for your help on this. I want to welcome our speaker, Amani Nuru-Jeter. Very, very happy that you're with us today. This lecture has really become a hallmark public event for the city. We're very proud of that. And indeed, it's a point of pride for the college and for the university. And today we have Provost Gable representing the university. Dr. Pastides hoped that he could be here, but he was called away. But thank you, Joan, for coming out and joining us. Now, this week is also a special week for public health. It's National Public Health Week, and it's a week where each day, at least for this year, each day we reflected on a major public health challenge for our country. Monday was Health Behavior Day. It had a focus on improving access to mental and behavioral health services, and particularly with the opioid epidemic that we're experiencing, that was a very appropriate topic. Tuesday was Prevent Communicable Diseases Day. That day had a focus on supporting comprehensive sexual health education in our schools to reduce sexually transmitted diseases, with also the positive spinoff of what? Preventing teen pregnancy. Wednesday was my favorite day this week. That was Environmental Health Day. We don't always have an Environmental Health Day in Public Health Week, but this year we did. And it was focused on protecting and maintaining a healthy planet by advocating for, and this is important, advocating for evidence-based policies to protect our air, water, and our food. And as you know, evidence-based policies are under attack at present. And Congressman, as an environmental health scientist, Scott Pruitt is making me crazy. I hope you can do something about that. Thursday was Injury and Violence Prevention Day. And yes, gun violence is a public health issue. And yes, we in the public health community have to take a vocal stand against it, and especially against the disparate violence that's occurring within our minority communities throughout the country. And today, Friday, you know what today is, other than being Friday? The topic today is Ensuring the Right to Health Day. So our speaker today, you're right on the mark with Public Health Week, coming and talking to us about health disparities, health equity, social justice, and other issues. Now, this premise of ensuring the right to health is the most fundamental premise of what we do in public health. We believe that everyone, everywhere, deserves an equitable opportunity to live a life that's free of preventable disease and free of disability. As a community of scholars within the Arnold School and elsewhere in the country, we strongly believe that everywhere we live, work, learn, play, and worship should promote our health and not threaten it. And you're going to hear more about that today. Now, this week also marked another milestone in history. It was the 50th anniversary of the assassination of Martin Luther King in Memphis, April 4th, 1968. But interestingly, and particularly relevant to today's events, almost exactly 2 years before Dr. King's death, on March 25th in '66, he addressed the Chicago Convention of the Medical Committee on Human Rights and made probably the most impactful comment on health disparities that he ever spoke. And we all know he spoke a lot. And this is what he said, and I just want to read it to you. We're concerned about the constant use of federal funds to support this most notorious expression of segregation. Of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. Then he went on to say, I see no alternative than direct action and creative nonviolence to raise the conscience of the nation. Folks, that was 52 years ago, and his message is still so pertinent for the situation that we find ourselves in today, particularly with regard to health disparities, health equity, and social justice. So on that note, I'd like to invite Professor Mahmood Khan to come up and make a few remarks before we get into the lecture. And thank you again for coming.
Good morning. On behalf of the Department of Health Services Policy and Management, it's my pleasure to welcome you all to this annual Clyburn lecture. We are happy to be part of this event as a co-sponsor of this event. I have a few general remarks, and let me start by saying that I'm not a political scientist, and my presentation today is simply an expression of anxieties of a concerned citizen. I guess you can say with age, you suffer from anxieties anyway. So it's just an expression of that. When we age, we often go back what we did in the past. I was thinking about many years ago, as a graduate research assistant, I was calculating Gini coefficient of income distribution of the world. I had to calculate income distribution for different countries of the world and the whole world taken together. You know that the Gini coefficient is a coefficient that varies from 0 to 1, 1 being the most unequal society theoretically possible. But in real life, we rarely see any country with Gini coefficient of more than 0.5. We also found that in the whole world, if the world was one country, the Gini coefficient would have been slightly higher than 0.6. But interesting part of it is that within each country, if you calculate Gini coefficient, none of the countries were more than 0.5. And in fact, what we saw is the countries where it inches above 0.5 or comes very close to the 0.5, those countries experienced very significant socio-political unrest. So inequality creates social unrest unless there is some corrective actions taken to address those concerns. So the natural question was, if 0.5 within a country can create so much socio-political unrest, how is that possible that the whole world the world order remained as it is when the inequality was much higher than any other country of the world? Maybe it was possible because the world was divided into nation states by rigid walls. So it could segregate populations, and when you segregate the population, the political processes become quite different. Then came the rapid globalization, and it became very rapid in 1990s, and we saw very impressive economic growth. GDP of the world increased from $47 trillion in 1990 to $112 trillion in 2016. It's an extremely high rate of growth the world has seen. Did US benefit from globalization? Yes. GDP of the USA increased by more than $14,000 per capita basis, on a per capita basis, increased by more than $14,000 in about 20 years. And the increase itself is higher than the current GDP per capita of China. So you can see how rapidly we grew compared to other countries of the world. But unfortunately, the income disparity in USA remained high and became even worse. Gini coefficient of USA in 1990 was 0.43. It became 0.48 in 2016, very close to the level of political unrest that we have seen in different countries of the world. So is it possible that something corrective action will be taken? Under the current political environment, we don't really see much that any action will be taken because most of the investment in education and health, if we want to make significant investment of that, we simply don't have the money. Why we don't have the money? 80% of our federal income tax revenue, the individual income tax and business income tax combined, if you take that, 80% of that is spent on defense and defense-related activities, plus debt servicing for the country. So there is really not extra money out there to do any corrective actions. So does it mean that we are heading towards a political crisis? You may say that it feels like we already are in one. Just like national boundaries, a semblance of stable socio-political order can be achieved in the short run by erecting walls of segregation. The forces of status quo would like to see walls between and among us, similar to the walls of segregation we saw in the past history of the country. Will these internal walls work? It is unlikely that it will work because segregating populations in this modern age and time is almost impossible. You cannot survive as a country without being connected with the rest of the world. So segregating population along social, economic, racial, and religious lines not only undermines basic tenets of human rights and dignity, but also acts as a brake to further economic progress and investment. So if we want to see the country progress economically, this type of segregation will actually be a brake for future development. So I'm hopeful that the progressive political forces and the leading industries of the country will steer us away from this self-destructive instinct of holding onto a straw to prevent drowning. I guess that's enough venting for today. Now let me introduce Dr. Lillian Peck, the Director of Public Health, South Carolina Department of Health and Environmental Control. DHEC is co-sponsoring this event, has been doing that for many years now. Dr. Peck is a physician by training, and she has a public health degree from Johns Hopkins University. Dr. Peck.
Good morning. I'm so excited to be here to celebrate public health with all of you today. So thank you for inviting me. The rising cost of healthcare and its share of our economy are driving healthcare to move from this episodic, non-integrated care towards a system that values health improvement for everyone. That's an opportunity for us in public health. Because behavioral patterns, community factors, socioeconomic circumstances account for as much as 60% of premature deaths, healthcare is increasingly turning to community for partnership. Working in public health for the past 2 decades and preaching primary prevention often to deaf ears, it has been amazing in the past 5 to 7 years to see the explosion of community-led initiatives where public health and healthcare sectors are working in concert with housing, transportation, social services, elected officials, and community members and organizations. It takes coalitions to improve population-level health outcomes, to address challenges such as educational attainment, economic opportunity, community safety, addiction, and healthy built environments. Efforts to make communities safer, thriving, and healthier are being launched all over the country, everywhere you look. Live Well Sioux Falls, Healthy Chicago, Healthy Living Matters in Harris County, Live Well San Diego, Mayor's Healthy City Initiative in Baton Rouge. And here in South Carolina, Columbia, Spartanburg, Greenville, Charleston, York County, they're all taking on this type of work. Collective action that invests in safe and healthy communities makes a difference for everyone, but especially those who are most disadvantaged. I'm excited that here in South Carolina, DHEC is working with the multi-sector group, the Alliance for a Healthier South Carolina, to create South Carolina's first state health improvement plan this year. We are looking at, in depth at the comprehensively at South Carolina's data and developing evidence-based strategies as a call to action for South Carolina to improve its health. As we continue to move forward, we are challenged to learn from past successes, what others are doing, what we're doing, build stronger connections, and evaluate our efforts to know whether they're working or whether we need to look at a different strategy. So I encourage everyone here today to take the inspiration that Dr. Jeter will offer us and take an action, whether it be big or small, whether it's your first or your next, to positively influence a system or a condition that affects our collective well-being in South Carolina. What might you do to affect the opportunity for every person in South Carolina to have a sense of purpose and feel motivated to achieve their goals, to have supportive relationships and love in their lives, to manage their economic life, to reduce stress, and to increase security, to like where they live, to feel safe, and to have pride in their community, and to have good health, both physically and emotionally. Thank you.
Well, now what we've been waiting for. Hi, my name is Jay Downing. I'm an assistant professor in the Health Services and Policy Management Department at the Arnold School of Public Health. And I'm delighted to welcome Dr. Nuru-Jeter, who flew all the way across the country from California to be with us today. Dr. Nuru-Jeter is a professor of social epidemiology in the School of Public Health at University of California, Berkeley. She has a doctorate from Johns Hopkins Bloomberg School of Public Health and a master's in public health from George Washington University. Dr. Nuru-Jeter has published extensively on the topic of race and health. She is the principal investigator of the African American Women's Heart and Health Study, which examines the association between racism stress, cardiovascular biomarkers, and biological stress among Black women in the Bay Area, and a co-principal investigator of the Bay Area Heart Health Study, which examines similar relationships among Black men. Her prior work has included research on doctor-patient race concordance, the intersection of race, socioeconomic status, and gender on risk for sociological distress, disability outcomes, adult mortality and child health and development, racial segregation, and racism stress in mental health outcomes. Quite a bit of things. Dr. Nuru-Jeter is not only an accomplished scholar, but also an accomplished and award-winning teacher. I met Dr. Nuru-Jeter while I was a doctoral student at Berkeley. Her course, Social Epidemiology, brought to life many of the concepts I grappled with in my research and influenced how I approach research and teaching today. So please join me in welcoming Dr. Amani Nuru-Jeter.
Morning. Thank you for having me, and thank you to everyone for taking the time to attend the lecture this morning. I'm going to try to put on this portable microphone in case I move around. Okay, can everyone hear me okay? So again, thank you for taking the time to attend the lecture this morning. I'm truly humbled by the honor of having been asked to serve as your keynote speaker for this 11th annual James E. Clyburn Health Disparities Lecture. And I want to give a special thank you to the organizers of this conference, the Arnold School's Office of Diversity, Equity, and Inclusion, the Department of Health Services Policy and Management, the South Carolina, I'm getting this straight, the South Carolina Office of Health, Department of Health, and Environmental Control's Office of Health Equity, and the USC Office of Civil Rights History and Research. So think about an interdisciplinary collaboration. Trying to memorize all those names was a little difficult. But thank you to all of you for organizing not only this 11th annual lecture, but this lecture series over the years. And I would be remiss if I didn't honor the tremendous work that Congressman Clyburn has done over the years to not only impact population health, but specifically health disparities, and I would even argue health inequities, in thinking about the efforts that we need to really put in place to really support the health and the needs of our most vulnerable population. So thank you, Congressman Clyburn. I'd also like to thank the Clyburn family for their support of this lecture series over the years. I had the pleasure of having dinner with Dr. Reed last night and others from the Arnold School of Public Health, and we had an opportunity to just kind of sit and talk and think about the ways in which health disparities plague our country, the state of South Carolina, and the ways in which, as Dr. Khan mentioned, social inequities impact health inequities, right? And thinking about the ways that we see that in our state, but also even just in our institutions, and starting to talk a little bit about some of the activities that we can engage in to try to help mitigate some of those disparities. So I'm very appreciative to be here with you today to talk more about that. So I'm going to be speaking this morning on the topic of racial health inequities, specifically, how does race get into the body, the embodiment of race, or the biological embedding of race. I've titled my talk, "It's the Skin You're In," which is a quote from a qualitative project that I did a few years ago, and it's a quote from a participant that was reflecting on her experiences as a Black woman, but specifically her experiences with racism over her life course. So what is this thing we call race, and how does it get into the body? So how many of you in the audience have read Ta-Nehisi Coates' recent book, Between the World and Me? Show of hands. Good, a few of you have, that's great. For those of you who haven't, I really recommend that reading. But in his book, Between the World and Me, and previously in James Baldwin's book on being white and other lies, they talk about people who think they're white. Not people who are white, but people who think they're white. And by that, they're referring to the social construction of race, something that's really just a figment of our imagination, an illusion built upon prejudicial beliefs, which led to a system of social hierarchy that determined differences in life chances and opportunity structures between groups, including the opportunity to live a healthy and productive life. So as Coates states in his book, race is the child of racism, not the father. And naming groups has never been a matter of genealogy or physiognomy, but of hierarchy. So in graduate school, I was introduced to the physiognomy model. Physiognomy is a study of physical characteristics and was historically used to argue both the intellectual inferiority and primitive nature of Blacks, both negative stereotypes that can determine one's sense of self and perpetuate prejudice and ultimately discriminatory behavior. Now, when we think about race and health, we commonly talk about race and ethnicity and often use those terms interchangeably. But in thinking not only about racial health disparities, because that just means difference, but racial health inequities, it's important to distinguish between the two. So ethnicity, as many of you know, on the right side of the model, refers to the shared values, beliefs, norms, and practices that define a culturally distinct group, all of which can lead to health and illness behavior and ultimately impact differences in health status. Race, on the other hand, is commonly viewed as more biological in nature and is related to deeply ingrained beliefs about the inferiority of some groups relative to others. So here on the left side of the model, it suggests that physical characteristics such as skin color, right, what people see when we walk around in the world, these physical characteristics such as skin color determine one's exposure to a variety of external, which is important, right, external, not internal, external risks and or resources that we're exposed to, ultimately impacting racial differences in health. So in other words, how other people view us determines the vector of resources and risk factors we're exposed to on a day-to-day basis, ultimately impacting, again, not only racial health disparities, but I would argue racial health inequities. So this is a photograph of Dr. Kamar Jones, the immediate past president of the American Public Health Association, which you know because she was here giving this lecture to you not too long ago. In the US, Dr. Jones is viewed as black. However, in Brazil, she's categorized as white. So her socially assigned race, how other people view her, determines how she's treated in those two different places. In one, she's in a position of social disadvantage, and in the other, she's in the socially advantaged group. Now, you might imagine how her experiences may have been different had she grown up as white in Brazil versus having grown up as black in the United States. Now, importantly, her underlying biological makeup would not have changed between those two places. However, the biological expression of her race, the biological expression of her social experience of race would have been different based on societal perceptions of her. So here we're looking at self-identified versus socially assigned race. And specifically, we're looking at self-reported health. So at the bottom here on the x-axis, we're looking at reports of excellent or very good health. And these are percentages, and each bar represents dyads of self-identified and socially assigned race. So if you look at the dyads at the bottom, on the left, we have self-identified race, and on the right, we have socially assigned race. So the first bar suggests that in the United States, 40% of those who self-identify as Hispanic and who society views as Hispanic report excellent or very good health. If we jump to the middle, then we see those who self-identify as Hispanic, but those who society views as white. We see an almost 15 percentage point jump in the percent reporting excellent or very good health. And that's just based on the difference in being socially assigned Hispanic versus socially assigned white. And then we see a more modest increase in going from self-identified white to, self-identified Hispanic to self-identified white. Right, a more modest increase there. So the biggest jump we see is based on socially assigned race, and we see the corresponding decline in reports of fair or poor health at the top. And importantly, this pattern is seen across groups. So if we look here at the top, we see those who self-identify as white and who are socially assigned white race, almost 60% reporting excellent or very good health. But among those who, instead of being socially assigned white, are socially assigned as Hispanic, we see an almost 10 percentage point decline in the percent reporting excellent or very good health. We see a much bigger jump, for example, if we look at Native Americans, a 20 percentage point decline based just on the difference in being socially assigned white race and being socially assigned as Native American. And so we see this pattern across many different groups. And so what we're basically talking about is health being largely determined based on how other people view us. And some may argue, well, this is self-reported health status, these are self-reported numbers, so how reliable can these numbers be? But what we do know about self-reported health is that it's one of the most reliable and common predictors of population health in the United States and is correlated very highly with more objective indicators of health. And so in thinking about how others view us, especially in relation to racial health disparities and racial health inequities, and going back to our physiognomy model, then we can consider racism and racial discrimination as perhaps two of those external risks that I talked about before that determine our experiences and our health outcomes. And so like race and ethnicity, racism and racial discrimination are often conflated. These terms are often used interchangeably, but I also want to take a moment to distinguish between them. Racism has been defined as an organized system premised on the categorization and ranking of social groups into races and devalues, disempowers, and differentially allocates desirable societal opportunities and resources to racial groups regarded as inferior. This system then often leads to the development of negative attitudes, i.e. prejudice, beliefs, i.e. stereotypes, towards non-dominant groups, non-dominant stigmatized racial groups, and differential treatment, i.e. discrimination, right? So in thinking about racism as an organized system, as an umbrella that manifests itself in numerous ways that impact the social experience of people's day-to-day lives. And differential treatment discrimination, which is what we see in a lot of our research, behavior of these groups by both individuals but also social institutions. And so what we're talking about here is this balance of risk and protective factors over the life course, where experiencing racism and racial discrimination tips the balance of the scales more in favor of risk versus protective factors, increasing the likelihood of poor health among socially stigmatized groups. And this idea of risk and protective factors is not new, right? Since at least the mid-18th century, there have been claims about the importance or the role of social factors in impacting health outcomes. Rudolf Virchow was a German pathologist working in the mid-19th century and is quoted as saying, "Do we not always find the diseases of the populace traceable to defects in society?" So this is a pathologist, and he's not saying that the challenge is with the infectious agent that happened to infect a host, but is traceable to defects in society. No matter whether meteorological conditions, general cosmic changes, never do these in themselves make epidemics. They only induce them whenever through poor social conditions, the people have lived under abnormal conditions for a long time. So again, reflecting back on that quote that I shared with you at the beginning, it's the skin you're in. It's just another part of your life. These are experiences that we've had over our life course, right? Living under abnormal conditions for a long period of time. And so when we think about living under these conditions for a long period of time, an obvious consideration is the experience of stress, of social stress, and the role that that plays in predicting and promoting health outcomes. So some of you may be familiar with this diagram. It is the general adaptation syndrome, or what we commonly refer to as our fight or flight response, which was coined by Selye in the 1950s. And so if we look at this diagram, it kind of gives us an idea of kind of our normative functioning in terms of how we respond to day-to-day stressors, right? And so this model suggests that upon the presentation of an environmental demand, our bodies kind of go into, certain parts of our bodies go into an arrested state. And for those of you over here, this alarm response. And so what this means, or what is represented here, is this kind of mobilization of energy stores from what we would consider to be non-essential parts of our bodies to more essential parts of our bodies, allowing us to operate optimally in the presence of stress. So what are some of these non-essential parts of our bodies? Well, when we're responding to stress, we don't necessarily need our digestive system, we don't need our reproductive system, but we do need our musculoskeletal system, our respiratory system, our cardiovascular system, our inflammatory system, right? So these energy stores are mobilized from these non-essential to essential parts of our bodies, again, allowing us to operate optimally in the face of stressors. But the idea is that over a period of time, either once we become accustomed to the presence of those stressors, or once those stressors are removed, we kind of come back down to resting state and physiologic balance is restored. So this kind of mobilization of energy stores is represented or characterized by the upregulation of a variety of stress and other hormones in the body that allow us, again, to kind of meet the immediate demands of stressors in our environment. And this is good in the short term. These stress hormones, cortisol, or you hear people say, my adrenaline is pumping, right? They're talking about their epinephrine, catecholamines in the body, that they allow people to operate optimally, and so this is helpful for us. However, in the long term, the overproduction and overcirculation of these stress hormones can become very toxic to our bodies, compromising our body's ability to regulate key biological systems, such as those systems that I just mentioned. But this activation and recovery process is normal, and that's what's represented here in this top box, allostasis. We activate and we recover. So in the literature, that's termed, or we define allostasis as maintaining stability through change, right? It's good to change. These four bottom boxes represent what we call allostatic load, which has been defined as the wear and tear the body experiences from repetitive experiences of stress. So again, the result of that prolonged circulation of these stress hormones in our bodies. And so what I'm going to be talking primarily about today is this top left box, the repeated hit box, which is what I call the chronic stress box. And so these 4 boxes kind of conceptually describe the kind of different elements of allostatic load. So for repeated hits, for example, you can see that we're properly going through our activation and recovery periods, but we're being hit one after another with repeated stress experiences that the end result is still this kind of chronic elevation of stress hormones in our body. Briefly, to describe these other 4 allostatic load models, when we look at lack of adaptation, remember I said that either once we become accustomed to the presence of stress or once those stresses are removed, we should kind of come back down to resting state. Additionally, when we're initially presented with a stressor or an environmental demand, when that demand is novel, then our cortisol and our epinephrine and a variety of pro-inflammatory cytokines might go up to some level. But upon the subsequent presentation of that same stressor where that demand is no longer novel, the idea is that we would kind of habituate, that we would adapt to the presence of that stressor. But what we're seeing here in lack of adaptation is that we're not properly adapting or habituating, and so we're actually mimicking repeated hits. And then when we look here at prolonged response, we activate, but we're not recovering. Right? And so there's a whole literature around what we call cognitive perseveration, or what in layman's terms we call rumination. We ruminate on these experiences, especially when they're very meaningful and salient experiences that color our day-to-day lives. So if our, say for example, cortisol goes up to this level, and we aren't able to let it go, and we don't ever fully recover, then what happens the next time we're faced with a similar or another environmental demand? Perhaps that's our new baseline, and you can kind of imagine the kind of snowball effect that this can have on our bodies. And then the last diagram here, inadequate response, shows that we never properly activate, which has its own set of physiologic adversities. So allostatic load. This definition of stress was provided by 2 of what I consider to be giants in the field of health psychology, Richard Lazarus, who used to be at UC Berkeley, and Susan Folkman, who's still at UCSF. And they've importantly have defined stress as a process in which environmental demands tax or exceed the adaptive capacity of an organism, resulting in psychological and biological changes that may place a person at risk for disease. So 2 important elements that I want to highlight in this definition. One is this idea of stress being a process. So often when I ask people, well, what do you think stress is? How do you define stress? I usually get one of 2 types of answers. Either stress is that thing in the environment that stressed me out, the environmental demand itself, so the stressor, or answers that really speak to the way that people are responding to stress. They say, I got stressed out, or I started sweating, I broke out in hives, I got a stomach ache, I have a migraine, right? But stress, importantly, is not the stressor or the stress response, but it's a process that involves exposure to an environmental demand, so the stressor, but then importantly, one's appraisal of the degree to which that demand is threatening, one's appraisal of their ability to cope with or manage those stress experiences, and then the corresponding biological, behavioral, affective, cognitive response, right? So it's a process. The second aspect of this definition that's important is this idea of adaptive capacity, right? So we each kind of have our own max beyond which we're unable to manage our stressors, right? So 2 of us could experience the exact same stressor, but one of us may appraise it as threatening and the other may appraise it as challenging. And based on the difference in those appraisals, we would have very different physiologic responses. So this diagram here is kind of a more visual depiction of that definition I just gave you. So we're all experiencing environmental demands, small and big, in our day-to-day lives. But importantly, those demands have to be filtered through us, through the appraisal of threat. Now, where public health has been for the majority of its history has been here, behaviors, right? Because we think we need to figure out how to fix people. That's what we've been doing since public health started, right? We need to teach people how to cope better, how to behave better, how to eat better, how to have safer sex, how to do all these things, because clearly they don't know, right? What we don't do as much of is considering the ways in which individual, community, population behavior are just maladaptive coping strategies. And so taking the onus off of the individual and asking the question, why is it that there's a non-random distribution of environmental stressors that plague certain groups and not others? So it's not about an individual learning how to cope better. Perhaps it's actually figuring out how to even the playing field when it comes to exposure to stress. But even if we take behaviors out of the picture, what we also know is that there's a direct relationship between the perception of threat and physiologic changes that's harmful to our health. So has anyone read Sapolsky's book, Why Zebras Don't Get Ulcers? So I recommend it for anyone who's interested in this topic of stress. It's a very easy read. So this is kind of a play on his book, and I'm just saying why zebras don't have stripes. So you have this zebra there, and he's like, I think it's stress. So Sapolsky in his book talks about and describes the role of stress, especially chronic and severe stress, in dysregulating homeostatic and allostatic systems in the body, resulting in physiologic disorder. Translating this to human populations, several scholars, including Bruce McEwen, Teresa Seaman, Alyssa Epple, you may have heard about some of these, and others, have shown a significant association between the experience of chronic social stress and physiologic dysregulation, as indicated by measures of allostatic load, which I just mentioned, telomere length, chronic inflammation, and others. Importantly, we know that there are racial differences in allostatic load, but before I go there, I want to kind of describe to you operationally what allostatic load means. So I've kind of described it to you conceptually, but how do we actually measure this when we're interested in understanding someone's health profile? So allostatic load operationally is a composite measure of a variety of different biomarkers that indicate functioning across multiple bodily systems, across the cardiovascular system, the immune system, different neuroendocrine processes, et cetera. And so Arlene Geronimus, who's a professor at the University of Michigan, did a study back in 2006 where she looked at race and gender differences in allostatic load. So what's important about this operational definition of allostatic load that I'm sharing with you is that we're not just talking about cardiovascular disease or low birth weight, or preterm delivery, or diabetes, or kidney function. We're talking about multi-system physiologic dysregulation that leaves people more susceptible to a variety of health outcomes. So from that perspective, it almost doesn't matter what the health outcome is, as opposed to thinking about the fact that there are people walking around in a compromised biological state every day. So that's the kind of measure that Arlene Geronimus used here. Now, when we think about our lives as we age, we expect that as we get older, the longer we live, we've accumulated more and more experiences of stress. So it's intuitive that, so what we're looking at on this diagram is on the x-axis age, and on the y-axis, the predicted probability of allostatic load. So it's intuitive that as we age, we would see this increase in allostatic load over time, right? We all would expect that. However, what we might not expect is to see this bifurcation between racial groups. So the two top lines here are blacks, the two bottom lines are whites. And so we see this bifurcation starting in the reproductive ages of the predicted probability of allostatic load over the life course, and we see that that disparity gets larger as we age. And then we also see a very interesting gender gap, but only among blacks. So that very top line is black women. And in this study, Arlene Geronimus showed an almost up to 5-fold higher odds of allostatic load among African American women. And this is after you control or adjust for various indicators of socioeconomic position. And so this is reflecting a hypothesis that she developed many years ago called the weathering hypothesis, which conceptually is similar to allostatic load, but describes the ways in which our bodies are kind of weather or age, kind of the cumulative toll on the body from the repetitive experience of stress associated with social marginalization, things like social and political and economic exclusion and experiences of racial discrimination over the life course. So she coined this term, the weathering hypothesis. So that's allostatic load. When we look at other measures of kind of this multi-system physiologic dysregulation, telomere length is another one that you may have heard of. So telomeres, which are represented by these kind of dark caps, this is a chromosome, so these dark caps at the end of the chromosomes. And what these are repetitive sequences of non-coding DNA that cap the ends of our chromosomes to protect from the degradation of the coding segments of our DNA, to protect from cellular senescence, et cetera. So what we know about telomere length is that telomeres shorten with increased cell replication. We also know that social stress is associated with increased cell replication, and numerous studies have shown an association between higher levels of chronic social stress and shorter telomeres. And so this is a measure of cellular aging, or we talk about it as physiologic aging. So Arlene Geronimus subsequently conducted another study where she used telomere length as a measure of physiologic aging and demonstrated that African American are aging on average about 7.5 years more premature compared to white women, right? And again, this is after adjusting for a number of potential confounders. And then in my own work, we have found that among Black men that we see this association between racial discrimination and telomere length, but that it's kind of the intersection of racial discrimination with other aspects of racism. So, right, so making that distinction again between racism, which is multifaceted, and behavioral acts of racial discrimination. And so one of the things that we found, which I'll show you a little bit more of later, is this intersection between experiences of racial discrimination and what we call internalized racism, or what some may consider having an anti-Black bias, right, where we buy in to the negative stereotypes that are presented to us about ourselves, and that together can shorten telomeres over time. And then if we look at cardiovascular disease, okay, so we see Black women being at the highest risk when we look at allostatic load. We see them doing pretty bad when it comes to telomere length. And then when we look at the leading cause of death in the United States, cardiovascular disease, and when we think about cardiovascular disease and we look at the research that's in the literature, we primarily think about men, and then we think about Black men. But when we actually look at the epidemiology of the disease, we see that Black women are among the most at-risk groups for cardiovascular disease, having the highest cardiovascular disease prevalence and the highest proportion of cardiovascular death compared to other groups. So the question then becomes not only how does race get into the body, because when I finished graduate school, my question, this slide, I didn't have this slide yet, but if I did, it would have said race getting into the body. But now what I know is that it's not just about how does race get in the body, it's how does race times gender get into the body. And one might argue it's race times gender, times socioeconomic position, times sexual orientation, times age, all of these kind of intersectional identities that we walk around in the world with every day. Right? So when I walk into the world, I don't walk around as just African American. I don't walk around as just a woman. I walk around as an African American woman of a certain socioeconomic status that happens to live in East Oakland, right? And when I go to the grocery store in East Oakland, they don't see Dr. Nuru-Jeter. That's not what they see when I'm in my Jordans and when I'm in my sweats. That's not what they see. And so I experience life just like any other Black woman does when they walk into the grocery store. But the question is, how does race times gender get into the body? So thinking about stress and cardiovascular disease, just to kind of give you a little bit of background, kind of playing on this idea of CVD as the leading cause of death, we know that chronic stress plays a critical role in the progression and etiology of cardiovascular disease, which may help explain the heightened risk of CVD among Black women. There's also a strong body of work linking chronic stress to cardiovascular disease via pro-inflammatory mediators, which promotes atherogenesis and a variety of other cardiometabolic risks. However, the pathways linking chronic stress to inflammation remain unclear. And even when we think about the association between chronic stress and cardiovascular disease, the majority of work that's out there has focused on physiologic mechanisms, with little attention paid to the psychosocial processes regulating these mechanisms. And so the literature is out there, right? Let's just all assume, take my word for it, that there is ample evidence in the literature linking the experience of chronic social stress to cardiovascular disease. Now, thinking about a particular form of social stress, racism stress, what does that have to do with health and illness? So we know from numerous studies that racism is reported as a chronic stressor among African Americans, but in particular among African American women, with upwards of 2/3 of African American women reporting exposure to racism at some point during their lifetime, with most reporting multiple experiences. We also know that Black women report greater levels of psychological distress from their racism experiences compared to Black men. Now, I do want to give the caveat that that doesn't mean that Black women are more stressed from their racism experiences, but when we use mental health indicators such as psychological distress, we have to think about what is the right way to measure distress between men and women, right? So getting back to that kind of race times gender. So it could be that because we haven't done as much around measuring behaviors and the way that we kind of see those differences between men and women, that we're not capturing the right things. But there at least is some literature showing that Black women report greater psychological distress compared to men. And then from my own work and also the work of others, we see that Black women appear to use what we consider to be unique cognitive appraisal strategies and coping style, specifically with respect to their racial discrimination experiences relative to other forms of social stress that they experience. Now remember, it's cut off actually on both of these slides, but at the bottom here I have an indication of this kind of newer way of thinking about stress, integrated specificity. So remember when I showed you the general adaptation syndrome? For the majority of the work that we've done in public health and in health psychology, when we think about stress and health, we've kind of considered that there's this standard physiologic response to any given stressor. That's kind of been the predominant thinking. However, more recent research coming out of UCSF suggests that it's more customized than that, and that is actually a combination of the specific types of stressors in combination with specific types of stress appraisals and particular types of coping styles that determine one's unique physiologic response. And so in thinking about that, I want you to keep that in mind, this idea that it's not just for any given stressor, but think about stressor type. What is the environmental demand? I want you to think about stress appraisal. How are people appraising these stressors, as threatening or as challenging? And then how are people coping with it? So now what I'd like to do is, going back to the quote that I shared with you at the beginning, is kind of walk you through a few examples of quotes. These quotes are from a qualitative project that I did a while back where we engaged Black women in describing their experiences and perceptions of racism and racial discrimination over their life course. And so again, listen out for those: exposure, appraisal, coping. And so this is Black women talking about their racism experiences. So one theme that was very prominent was this idea of racism being experienced over the life course, right? This idea of it being chronic. And so this one woman says, I think that the most difficult thing that I faced was when I was 8 years old. And when I had to learn, so importantly, 8 years old, that's an age during middle childhood, right? Happening early in life. And the majority of women in our study reported that their initial experience of racism was commonly during early or middle childhood. And then she didn't say when I learned. She said when I had to learn, almost as if she didn't have a choice. When I had to learn, we weren't all equal. I don't even think I knew the difference between black and white. I used to play with this white girl every day, like she was like my best friend. She would always come to my auntie's house. And then there was one time where I went to her house, and she said, well, my parents said we can't allow anybody black in the house. And that's something that always stayed with me my whole life. Remember prolonged response, right? Stayed with me my whole life. And that was really, for a little kid, heartbreaking, you know. And that's when I first learned, right? She didn't say when I learned. She said when I first learned, suggesting that that was the first of many other experiences, that there's a difference, you know, with the colors. I thought about it a lot. I still think about it, cognitive perseveration. Women also talked a lot about, and this is one way that gender and race come together, about their concern for their children, right? So women endorsing this traditional role norm of being caregivers. So I'm stressed because now that my kids are getting older, they go through it all the time. I take that in internally. It's subtle. So that's that kind of microaggression, subtle form of racial discrimination that we hear about now. It's not out in the open like slavery days. It's like hidden, but you feel it still. As adults, it seems like I could overlook it. But you have kids coming home every day. Oh, he called me a nigger or black. That affects you as a parent. I go through the hurt when they go through the hurt. So again, this kind of intersection between race and gender. So what we also know from the literature is that women tend to report higher levels of what we call network stress. So women report distress not only from the things that happen to them, but the things that happen to others in their social network. Whereas men tend to be more egoistic in nature, where they tend to report higher levels, not egotistical, but egoistic, meaning that they tend to report more distress from the things that happen to themselves. Anticipatory vigilance. So women reported this kind of orientation around being hypervigilant. So women talked about, every day when I walk out the house, I put on my armor because I have to be prepared just for the possibility of being treated differently because of my race. Right? So regardless of whether or not one actively ever comes across an objective stressor, kind of walking around in this state of anticipatory vigilance. And what we know from the stress physiology literature is that just anticipating a stressor is enough to initiate the biological stress response. So it's like you get tense because I know this person is going to say something that's going to make my heart rate go up, or maybe have to hold back my tears while I'm talking to them. Hold back my tears, emotion suppression, right? I don't want them seeing me crying because I don't want them thinking I'm sad. I'm not sad, I'm mad. You just get tense because you have to brace yourself for something stupid that they're going to say. With a white person, you know that some level of racism is going to hop out of their mouth, and so you have to prepare your body for that. So I'm sitting here facilitating these focus groups, and I'm hearing these women say, you get tense. You have to brace yourself. Right? You have to prepare your body for that. And I'm thinking, what's happening inside, right? What does this mean physiologically? Suppression. So realistically, it's going to affect you. It does bother you. You just put it in a different place. You learn to accept it, not to trip off of it no more. And at the bottom, the title of my talk, it's the skin you're in. It's just another part of your life, right? This is just kind of what we deal with. Impression management, so I'm going to skip through some of this for the sake of time, but you kind of get the point, right? They also talked about kind of some of the physical signs that they see when they're experiencing stress. So importantly, when we look at the literature around racism in health, we see a lot of mixed evidence, especially in the physical health outcome literature, specifically around cardiovascular health. There's a lot of mixed evidence, and what we primarily see in the literature is studies looking at exposure at the top and then health outcomes at the bottom. So the association between exposure to racial discrimination. So have you ever experienced unfair treatment in any of the following domains? And is that associated with low birth weight? Is that associated with hypertension, right? While neglecting to capture two key elements of the stress response process, threat appraisal and coping, right? So this is why I went through that definition of stress. So we have a lot of literature looking at environmental demands and health outcomes, but then we're not capturing these two very important aspects of the stress response process, which has been a big motivator of the work that I'm doing and the work that many are doing in the field. And so the African American Women's Heart and Health Study was kind of a culmination of a lot of these ideas coming together, where we endeavored to examine the association between chronic social stress, with racial discrimination being one form of chronic social stress, and both mental and physical health among African American women in the San Francisco Bay Area. And importantly, our goal was to not just capture exposure and outcome, but to capture exposure, appraisal, coping, and outcome, to more accurately capture each stage of the stress response process. And we were particularly, I'll come back to this in a moment, but here's a snapshot of the different measures that we included in the study, right? So capturing various ways that racism presents itself. So looking at racial discrimination expressed through kind of major acute experiences, those more subtle microaggression forms of discrimination I described to you, looking at discrimination experience in different life stages, so childhood, adolescence, adulthood, looking at both direct and vicarious experiences, so not only the things that happen to us, but the stories we hear when our children come home, when our spouses or our partners come home, our coworkers, our friends, etc. And we also measured a variety of other psychosocial factors that we thought might modify the association between discrimination and health, really thinking about what are the things, the levers that we can push and pull that might help mitigate some of the negative health outcomes associated with racial discrimination. We looked at a variety of health outcomes. So this study included survey research methods of physical exam, blood draws. We collected a variety of sociodemographics. And then we also did some original measurement development, so trying to capture some of what I shared with you in those quotes. So going back, one interest was in capturing that idea of anticipatory vigilance. So remember earlier I said that Black women seem to use unique coping styles and appraisal strategies. So this idea of kind of walking around with this kind of anticipatory vigilance was what we kind of see as this kind of culture-specific or culturally relevant form of threat appraisal, where women, Black women in particular, are more likely to appraise those kinds of stressors as threats because they're walking around in this kind of anticipatory state. And then Superwoman schema at the bottom. I took that slide out. Superwoman schema at the bottom. So some of you may be familiar with this, but kind of a unique orientation that might lend itself to the kinds of coping styles that Black women use when responding to racial discrimination. So Superwoman schema is this kind of confluence of active and passive coping strategies. It includes things like feeling an obligation to present an image of strength when one doesn't necessarily feel strong, feeling an obligation to suppress emotions when one doesn't really want to suppress their emotions, and you saw some evidence of that in the focus group quotes that I shared with you. Feeling an intense motivation to succeed, resisting the idea of being seen as vulnerable, and importantly, feeling an intense motivation to nurture and take care of others while neglecting their own self-care. So kind of being a superwoman. So I'm going to share with you now kind of a series of results from some studies that we've done using this data, the African American Women's Heart and Health Study data. So this was a community sample of 208 African American women, midlife African American women, residing in the San Francisco Bay Area. We used multiple recruitment strategies. So we did general street canvassing, we did targeted neighborhood sampling, going to neighborhoods that were both higher and lower SES, had higher and lower densities of African Americans to kind of maximize heterogeneity and some of these key exposures of interest like racial discrimination and socioeconomic position. We went to events. I mean, we had teams out. We got the event schedules, the concert schedules of all the venues in the Bay Area. We stood out in front of the Alvin Ailey performance, out in front of all the jazz concerts and the Yoshis and all of the Juneteenth festival to try to really blanket the city. So we did venue-based sampling, so transportation hubs, churches, barbershops. You know what's great about churches and barbershops and nail salons? I don't care how much money you have. If you're a Black woman, you're going to find a way to get your nails done, and you're going to find a way to get your hair done. And if you're a Black man, you're going to find a way to get their hair cut. When you go to church, people call church the most segregated hour of the week, right? Segregated racially, but very integrated socioeconomically. So these kinds of venues are excellent places for community recruitment. We did a lot of organization-based sampling, trying to recruit because we knew that our $70 incentive wasn't going to be that much of an incentive for higher socioeconomic groups. So we worked with 100 Black women of the Bay Area, the Links, the different sororities, Delta, AKA, et cetera, the National Pan-Hellenic Association. We did social media sampling, and so this wasn't random sampling, and I'm telling you all this because it's very difficult to recruit African American populations because of the history of racial discrimination in medicine and the very high degree of medical mistrust and institutional mistrust. So one of the things we learned when going out into communities, that them seeing us, feeling us, talking to us was really important. Wait, well, I'm not just trying to, and women would say to me, well, wait, you don't want me to just answer a survey, you want my blood. Well, why do you want my blood, right? So when you want to ask people for their blood, then I felt like it was important for them to see me out there. It's me. I'm the one doing the study. So I would kind of be out there recruiting with all of my research assistants, and it was really eye-opening. So skipping past some of so this is me now, right? So I collected all this data, and now I'm realizing that I actually have to analyze it all. So now getting to some of the results. So this first result I'm going to share with you kind of comes from a subsample of the 200 women, 135 of the women for whom we had complete data on biomarkers at the time. And so this is kind of just a summary of these 135 women. So you can see that there's very good diversity in terms of socioeconomic position. So half were employed, 2/3 had more than a high school diploma, 20% were married, half were above and below the federal poverty level, and in general, they reported very good health, right? 74 and 77% reporting excellent to very good mental and physical health. So the first thing I did was I wanted to look and try to replicate this association between racial discrimination and health, and so I looked at racial discrimination in relation to 15 different biomarkers. So remember that measure of allostatic load I described to you before? Before putting them all into this composite measure, I wanted to try to get a sense of how racial discrimination might impact these biomarkers individually. And lo and behold, I found nothing. Of these 15 different biomarkers, I only found one significant result, and that was for elevated blood glucose. So of course, at this point, I'm thinking, what a monumental waste of time. I've been spending this last year collecting all this data, spent all the little bit of money that I had. But then what I was happy to see was that all the results were in the moderating effects of anticipatory racism threat and superwoman schema. Here's the superwoman schema slide. It's misplaced. So anyway, I've already gone over that, so I won't go over it again. So here are some of the results. So here, just looking at one of those discrimination scales, the everyday discrimination scale, which is one of the two most commonly used measures in the public health and epidemiologic literature, and this gets at that more subtle microaggression form of racial discrimination. We found that the association between everyday discrimination and health was exacerbated among those reporting high levels of anticipatory racism threat. And the pattern that we saw in these different factors here just represent the different dimensions of anticipatory racism threats, because it's a multidimensional construct and scale. But what we're seeing is this kind of chronic, the way that health is impacted is through this kind of chronic low-grade inflammation. Right? We see that consistent across all these different factors. And then, so these are just the numbers that go along with those findings. So here at the bottom, in the red circle, is where you have at least moderate or high on both of those factors. So this represents those interaction results. And then when we look at superwoman schema, we actually saw the opposite. We saw that the association between everyday discrimination and, again, what emerged was inflammation, but it was buffered among those who reported high levels of superwoman schema. And here are the numbers that go along with that. So you can kind of see the numbers are of the same magnitude as what we saw with anticipatory racism threat, but there's a minus in front of them representing the inverse association. So in another study, we're looking at racial discrimination and cumulative, so not just looking at individual biomarkers, but now looking at allostatic load as this composite measure and looking at the ways in which that might be modified by socioeconomic position. And so these are our study aims. And here we're looking at a different discrimination scale. Here we're looking at the experiences of discrimination scale, which was a measure developed by Nancy Krieger from Harvard. And this kind of taps into, unlike the other scale, which tapped into the more subtle microaggression forms of racial discrimination, here we're looking at more major acute experiences of discrimination. So have you ever experienced discrimination, been prevented from doing something, or been hassled or made to feel inferior in any of the following situations? So the everyday discrimination scale, which I'll show you a little bit later, the items that you see are kind of more of the everyday situations we might find ourselves in. Here we're looking at more major situations, such as I was prevented from getting a job. I experienced it at work. I had a hard time with respect to experiencing discrimination and getting housing, getting medical care with police or in the courts. And so this is our measure of allostatic load. So you can see here the 15 different biomarkers that we used representing the systems. I don't know how clear this is for those of you who are in the back, but the metabolic system, the cardiovascular system, the neuroendocrine system, and here we have measures of both the HPA axis and the SAM axis, which together comprise the primary stress response in the body, and then the inflammatory system. And we measured allostatic load in multiple ways. I'll save that for the Q&A. I won't go through all of it now, except to say that we measured it in different ways to try to assess how robust our findings would be across kind of different ways of assessing this kind of physiologic dysregulation. And so here we use the entire sample of 200 women, and you can see a summary of the sample. A summary of the sample here. So same thing, diverse socioeconomically and in fairly good health. When we look at racial discrimination, so what we see here is that 25% of women are reporting at least high or very high levels of racial discrimination. And here's a distribution of the items that make up the EOD scale. And you can see the ones that are most commonly reported on the street or in a public setting, from police or in the courts, at work, getting hired or getting a job. And then again, as I mentioned, this is a fairly healthy sample. So the way that allostatic load was measured was high risk or low risk. So you get a 1 if you're high risk, a 0 if you're low risk. There were 15 biomarkers, so the score ranged from 0 to 15 for the top two measures, and then 0 to 30 for the bottom measure, because we were trying to capture a more graded association. So there we scored at 0, 1, and 2 to capture not just at risk or not at risk, to avoid the misclassification that can be associated with these kind of dichotomous coding strategies. We wanted to look at low, moderate, and high. But you can see if this is scored, or if the range is 0 to 15, this is a generally healthy group, right? 2 and 6 out of 15, and then only 11 out of 30. So this is one of our primary findings. So what we see here is the association between racial discrimination on the x-axis, allostatic load on the y-axis, and then the differences in those associations based on one prominent indicator of socioeconomic position, educational attainment. And so this solid line represents those with higher levels of education, and here that's just coded as those with more than a high school diploma. And what we see here is we see some interesting patterns. So here our reference group is moderate, right? And again, I can talk about that in the Q&A if you like, but there's ample evidence that moderate levels of stress is actually health protective. But when we look, compared to moderate, those reporting lower levels of discrimination have lower levels of allostatic load. Right? That's pretty intuitive. That makes sense. What's less intuitive is those reporting very high levels of racial discrimination have the lowest levels of allostatic load. That doesn't make as much sense, right? What might be happening there? So again, I'll let you all sit with that for a moment, and we can come back to it during Q&A. The other thing we found looking at the lower education group is, as we might expect, compared to moderate, those reporting high and very high levels of discrimination have higher levels of allostatic load. However, look down here. Those reporting low levels of discrimination have higher levels of allostatic load. Again, really strange, although it's consistent with some of the other literature and some of the other findings we see. So again, we can talk about that later, and there are some really good potential hypotheses that would support these findings that we're starting to explore now. The other thing we did, so this is the everyday discrimination scale. So we're also kind of looking at what is racial discrimination? What is racism, right? So again, racism manifesting itself in lots of different ways. So it's important to think about the ways in which different measures of racial discrimination may impact health differently. Do they all mean the same thing? Does it matter how we measure it? So this is the everyday discrimination scale, and you can see a big difference in the items that I showed you before and the items that are here. So just when you're walking down the street, people act as if you're not smart. They act as if they're afraid of you. People act as if they're better than you. You're followed around in stores. Any head nods? Okay. You're followed around in stores. You're treated with less respect, less courtesy, etc. And here are some of the items that were most highly represented in our responses. So people acting as if they're better than you are. You're treated with less courtesy, less respect than other people. And here what we found is that actually the type of discrimination actually matters. So looking at the green line, this is the EOD scale, the one that I showed you in the prior set of results, and it's the same pattern that we saw before, right, where very high levels of discrimination is associated with lower allostatic load. But this orange line basically is demonstrating that there was no significant effect looking at everyday discrimination. So why might that be? And this is really informative because if we are going to impact change, how do we levy that change? What do we target? What kinds of unfair treatment do we actually try to target? These are some findings from, remember earlier I talked about that anti-Black bias or internalized racism, and so here we're showing that there's an association between racial discrimination and telomere length, so what I showed you before. Higher levels of discrimination are associated with shorter telomeres, but among who? Primarily among those with an anti-Black bias or those with internalized racism. So some of you may be familiar with the implicit association test. So implicit bias is really about kind of the subconsciously, how do you feel about your group? I mean, we found this for telomere length as well as with hypertension, so we're starting to see this pattern replicated across different kinds of outcomes. And then in thinking about looking at discrimination over the life course, right? So I was talking with a gentleman earlier. I saw him in the audience somewhere earlier. Yes. I forgot your name, I'm sorry. But we were talking about the importance of childhood experiences in kind of setting the stage for what happens over the life course. And the majority of work out there kind of looks at adulthood, either ask questions about in the past 12 months or ever in your lifetime, so we're not able to disaggregate what's happening at different life stages. And so we looked at the association between racism over the life course at different life stages, and this is just a correlation matrix showing you the different measures. And here I've just put red boxes around it to show you how low these correlations are. Right? Some of them are low, some of them are in the more moderate range, but basically what this is showing is that these are not the same exposures. These are actually capturing different things. And when we look at the results, we looked at childhood, adolescence, and adulthood, and in each of those life stages looked at both direct and vicarious racial discrimination experiences in relation to risk of miscarriage. And what we found was that with adult direct racism, we only found two significant findings. One was for adult direct experiences. So direct experiences directed toward you as an individual during adulthood, we found 13% higher odds of miscarriage among this group. But surprisingly, and that's just the graph that goes with it, which I'll skip for now, surprisingly, the strongest effect was found for adolescent vicarious experiences, which is kind of double what we saw before. So before we saw 13% higher odds. Here we see 35% higher odds of miscarriage among adolescents, women reporting that during the time of their adolescence, they experienced significant vicarious racism, meaning hearing about the racism experiences of others. So this is just my study group. I'm going to skip that. So why is all this important? So I want to come back now to the question that I was asking at the beginning, which is, what is race? Right, when we think about, not just health disparities, but racial health inequities, and we think about the embodiment of this thing called race, my hope is that I've at least convinced you that part of what we get when we look at race is social in nature, right? Because unfortunately, we are still faced with a lot of literature, a lot of questions, and a lot of conceptualizations of race in the field as race is biological. Although we know, and this is probably going to sound cliche to many of you, that there's much more genetic variation between than within groups, but despite all of the evidence that we have, we still see studies like this that set out to study race as explicitly biological. So here the author says, in the United States, the gap between black and white babies' birth weights has remained largely unexplained. So how are we going to try to explain that? They go on to say, rather than trying to measure all of the relevant variables, we use a genetically informative model, right, which already tells us what their ontological beliefs are about what race is, how they're conceptualizing race. And this is their results. So basically what they found was that it wasn't genetics. It was shared environmental characteristics. This was a twin study, and they found that it was shared environmental characteristics such as things like poverty that explained differences in birth weight. But this is what they said in their discussion section. Therefore, the relatively large shared environmental influences may be explained by a birth weight specific component labeled maternal effect. So basically what they said was that we found that it's things like poverty that matter, but that's really probably explained by something else we didn't measure, maternal genes. That's basically how they interpreted their findings. So as you might imagine, this met with quite a bit of criticism in the literature. So one author criticized them in saying that these authors used race as a proxy for genetic variation, which subverts even the most positive attempts to understand the impact of genetic variation on demographic processes. And the author's statistical results really restate their anachronistic theory of race and its association with health. Another critique, their findings indicate that this difference may be explained by shared environmental influences rather than by fetal genes, yet they insist that their conclusions have a strong genetic component. So this is really, again, representing their conceptualization and their reflection of race. And we see this across different studies. Despite what we know about race, despite all the evidence that I just showed you, and I've only showed you a small snapshot of my own work and a lot of the work that's out there demonstrating the association of the social experience of race and health outcomes, we continue to see studies that set out to study race as biological. But going back to this idea of generalized susceptibility, when I talked about Rudolf Virchow earlier, going back to a speech that John Castle gave in the year of his death, he said that throughout all history, disease has not been prevented by finding and treating sick people, sick individuals, but by modifying those environmental factors facilitating its occurrence. So what does that mean for us when we think about population health and health disparities? What does it mean to have more of a population health approach? So Jeffrey Rose kind of talks about, and a lot of people talk about, affecting change at the population level. And what we're really trying to do is, okay, right here, imagine this as being the population mean, right? And what we're really trying to do is shift the population mean so we improve the health of everybody in the population. And that sounds all well and good, right? And that takes us away from just focusing on individuals, but focusing on populations. However, an unintended consequence of that is that there are certain people in our population that are going to be able to take advantage of these population level interventions more so than other groups because of social disadvantage. So what we end up with is this differential intervention effect where the concentration of benefits and the concentration of risks remains the same, and certain groups, again, are able to take more advantage of that. So what we need to then think about is not just the population mean, but really looking at the shape of the distribution and really thinking about health disparities. So when we think about the interventions, and I won't go into this in a lot of detail, but arguably what we want to do, so these are all different ways that health can be affected if we levy population health interventions. Here, P equals population, I equals inequality, W is worse, and B is better. So this shows what happens when you institute these interventions, policies, programs, et cetera, and who is impacted. And so ideally, we want to be down here, where we not only shift the population mean, but where do we see the largest improvement in health? Those that were at the highest level of risk. So ideally, we would be impacting not only population health, but health disparities. But I would like to suggest to you that the causes of population health are not the same as the causes of health disparities. So we can't do business as usual. We can't look at the same factors. We have to start thinking about not interventions focused on equality. I hate that word, equality. Because equality, if we start out at different levels, all it does is perpetuate inequities, right? It does nothing to level the playing field. So instead of thinking about equality and inequality, we want to think about inequities. So I'm going to leave you with this cartoon, and I'll walk you through it. So you have the white guy getting on the black guy's back who's in shackles, and the white guy saying, "This is for your own good. This is good for you. Let me climb on top of you and get up on this ledge." "Oh, get off me, get off me." And the white guy is struggling, but ultimately he gets up on the ledge, and the black guy says, "Enough, I'm getting up." His shackles are gone, but there's a difference in the playing field. And then the white guy realizes, you know what, I'm sorry about being racist before. I know better now. So then the black guy says, "Okay, well, help me up." Well, of course not. That would be reverse racism. Right? So this is where we are, in an unlevel playing field. And what that means is that we can't give everybody the same thing. What we have to do is give the people who have historically been disadvantaged, whether that's by race or anything else, more, if we are really willing to acknowledge the initial historical injustices that led to the difference in the playing field in the first place. And this, again, is not about fixing people. It's about creating environments that allow every person to live and thrive to their fullest potential. And this, I think, has a role for us as scholars, as academics, as students, but it also has implications for our health departments, for our policymakers. There's a reason why certain neighborhoods look the way that they do, right? Some may say that redlining is a thing of the past, but redlining, we still see the patterns of racial segregation present in contemporary society, and I could go on and on. But the moral of this story is really for us to not just look at individuals and for us to really start thinking about equity-focused interventions, policies, and programs that can improve the health not only of the population, but to reduce health inequities. So with that, I will close and open the floor for questions. Thank you. Social pressure, everyone's standing up now. Thank you for your time. I did see, I thought, a hand or two, or I saw someone with a microphone. So if anyone has a question or not, yes, please.
Started the talk talking about public health in the age of health promotion. Mm-hmm. And if you look at the history of public health in the age of health protection, there's a really interesting lesson that could be learned. So, for example, I think it was in the 1880s, there was a guy who got up in the British House of Lords and said, well, you can't give people latrines because they're not going to be able to use them. Mm-hmm. And, you know, if you look at the history of what we did during that era, we dropped infant mortality rates from over 200 to about 20 in about 25 years with these engineering controls. And unfortunately, blacks still have that infant mortality rate of around 20. That's a little ironic that it's still stuck back at the population average rate back in the early 1900s. How do you see that as a parallel for what we could, or informative for what we're doing now?
Well, actually, I'm really glad thank you for that question, and thank you for that example, because I actually think that's perhaps the best example when we look at black-white disparities in infant mortality of exactly what I was demonstrating at the end here. So I could show you many graphs of different population health outcomes, infant mortality, cardiovascular disease, diabetes, and I'm talking about mortality, not just having the health condition. And what you will see is exactly the pattern that you described, that over the past 50 years or so, we've learned a lot about how to improve population health. And we look at the curves, the lines have gone down. Population health, all of these mortality rates have declined dramatically across all of these different health outcomes for every single group. However, if instead of one line on that graph, if I had different lines reflecting different racial groups, you will see that although the slope of the line is the same for all groups, the gap between different groups has remained consistent. So we've done nothing to minimize the gap in disparities over time. And again, infant mortality is probably one of the worst. And in fact, what we see with black-white disparities in infant mortality is that the disparity is greater at high versus lower levels of socioeconomic position, which I think also speaks to this issue of racial discrimination and other social stressors. And so I think that this gets back to my point about how the causes of population health, i.e. the decline that we've seen, is not the same as the causes of health disparities, and everything that we've learned hasn't really made a dent in the inequities that we see. I will say, though, that the other good point that you make is about the role of public health interventions and being the primary determinant of that large decline in population health. So if we kind of looked at when vaccines were introduced and different biomedical interventions, but then we also looked at kind of juxtaposed that with the sanitation movement and other kind of large-scale public health interventions, we actually see that when those larger public health interventions were instituted, that it was really the cause of a majority of the mortality in the decline in mortality that we've seen in our country and in other places, because when those other biomedical interventions were introduced, the majority of the mortality decline had already happened. from, again, these large-scale public health interventions. And so I think that, again, that infant mortality says a lot about, again, we've learned a lot about population health, but, what are we going to do to actually impact disparities and bring those groups up? Black women still experience 1.5 times the infant mortality rates in lower socioeconomic groups, but in higher socioeconomic groups, it's verging on the order of 3-fold differences. So it's problematic. And another point that you made, and I'll say this and then I'll stop, is that, we do kind of live in this era of risk, and we're always thinking about risk. And so you made a comment about protection. And so could we perhaps change our questions and not just think about who's the most at-risk group or what are the risk factors, but what are the resiliencies in the population? What are some of the beneficial kind of resilience factors, protective factors that we can try to leverage in order to kind of, again, level that playing field? But we do have this kind of prominent focus on thinking about risk that perhaps we're not identifying the protective factors in our environment that can really be leveraged to decrease these inequities. Thank you for that. Yes.
You talked about two challenges we face. One is getting away from focusing on individuals and focusing at the population level, and maybe we're making some progress there. But the other at the end was when we intervene at the population level through policies and programmatic actions, we leave some people behind because they don't benefit. Yeah. So it seems to me that we need to invest in learning more about why some people have a potential to benefit and some people don't from various actions, and then do something about that, because otherwise we'll continue to have inequities, because there are people who just don't benefit. So what are your thoughts about how we can, as a public health community, do a better job of figuring out how to do that?
Yeah. Thank you. That's a good question. And I'm not going to presume to have the answer to that question, but some thoughts that kind of go through my mind immediately is kind of this idea of addressing vulnerability. So when we look at graphs, commonly what we see on the x-axis is like health, right? We're trying to improve health, move the needle on health outcomes. But what if instead of on the x-axis, instead of health, we actually had social risk? How do we change social risk? How do we change the fact that people live in certain kinds of environments that don't have grocery stores, that don't have parks so people can go out and take an evening stroll? Years ago when then Secretary Thompson was announcing the, at the time, new dietary guidelines, he kind of slammed his hand on the podium and he said, "I challenge every family to go out and take a walk after dinner." Well, if I showed you West Oakland, where I used to live, and all the grocery stores in my neighborhoods had chicken wire around them, there were no parks, I'm not going outside to take a stroll after dinner, right? Our neighborhoods fundamentally look different. I had the ability to get in my car, drive on the other side of the lake, and go to the nice farmer's market over by Grand Avenue. However, if I showed you a picture of the farmer's market in the neighborhood I lived in, you probably wouldn't want to go there, right? So if instead of trying to address risk, because when we move the needle on health risk, we're addressing the majority of people who are in that normal curve, right? We're improving health for the majority of the population, and the majority of the population is not at risk, right? So how do we address those people who are in the tails of the distribution? And I would argue that we have to address social risk, and then going back to something that Dr. Khan said at the beginning is that social inequities are health inequities. Our goal doesn't always have to be to improve a health outcome. If we improve health conditions and social vulnerabilities themselves, then perhaps then the population level interventions that we institute will actually have a similar effect on everyone. But that requires everyone to be able to actually take advantage of those. Right? And so I think kind of focusing on, and so my doctoral degree is actually, I'm a social epidemiologist, but it's not in epidemiology, it's in health and social policy. And my program was all about identifying the connection between social policy and health policy. Social policy, education policy is health policy. Transportation policy is health policy. City planning efforts are health policy, right? We need to bring all these people together. Why is it that in certain neighborhoods we have an over-density of off-premise liquor establishments, more advertising for alcohol use and other substance use, and we don't have that in other neighborhoods? Why is it that if we believe and understand the implications of historical redlining practices that initially created differences geographically in area level space and where people lived, do we now have policies on the book where our schools are funded through property taxes? That makes no sense. Because of racial residential segregation, certain kids grow up in certain neighborhoods. And because of the way our education system goes, the neighborhood you grow up in, that you're born into, you go to those schools. But the property tax base is lower in certain neighborhoods, so those schools are inherently going to be under-resourced. Why don't we look at education funding in this country, right? That's changing vulnerability, that's social policy, but that's health policy. We know educational attainment is one of the most powerful predictors of population health. And we cannot argue that at age 8, when our kids are in school, that our job is to teach them how to behave better, that they don't know how to cope, that they've made a lifetime of poor choices, right? Certain groups of people are starting out in a worse place due to no fault of their own, and that's about social policy. So, I mean, those are just kind of some initial thoughts, but I mean, I think that we have to think bigger than just individuals and just about cardiovascular disease or birth weight or this or that. Yes?
Thank you for coming. This is a little different question here. You mentioned the grocery store, the hat to the back, and the warm-ups and all that. How would you compare that when you go to California, Berkeley, and the other environment? Could you compare the differences as a black woman, a dynamic diva?
You mean when I go to my grocery store versus when I go to work?
The perceptions, that you were saying that.
Right. Well, I know how to code switch with the best of them. So when I go to my job, I know how to perform my race and gender in that environment, because these are performative issues, right? These are performative factors, our social identities. But I do that, and this is really what gets at the essence of your question, I do that because I know the perceptions that others have of me. And I know that I have to perform in those environments in ways that are very different than the ways that I don't have to perform in my everyday life, when I'm at home, when I'm with my friends, when I'm with my family members, when I go to the grocery store. And so that brings with it a certain amount of stress, right? That I have to put on my armor, that I have to wear the mask when I go to work, because when Freddie Gray got killed, one of my white colleagues came to my office and said, I want to talk to you about that. And I had wrapped my door in I Am Freddie Gray posters. And so he came to my office after a long day of work, and I had just gotten out of class. And he comes in uninvited and sits down in the seat across from my desk and says, I want to talk to you about that. Why did he run? Really? That's the conversation we're about to have after I just got out of class? So how do I make that, and we were talking about this at dinner last night, how do I make that an educational moment? How do I perform and not have on my sweats and my hat to the back in that moment and say what I really want to say, and really think about how to perform in an environment and try to address some of the inequities that are even in my place of work, right? And so I think that, we've probably all, I see a lot of head nodding in the audience, so we've probably all, regardless of whatever our social identities are, have had to experience this. And so I think we are made to perform in different ways because, importantly, we know how people perceive us. And so this idea about socially assigned race, socially assigned gender identity, socially assigned whatever it happens to be, it can be this kind of constant cause of reflection. There is having to think about that every day. That's an experience, a cognitive load that some people have to carry that others don't. And we all deal with stress every day, but there are certain groups that have an additional burden because of the stresses that they experience. So I know that wasn't necessarily an academic question, but I hope that I answered you the way, because that gets at what we do every day, right? The hallways that we walk through, the work that we do. As a black woman doing work on racism, when I started at UC Berkeley, I had many students coming to my classes saying, well, Professor so-and-so said that's not a real thing. And so now I have to sit down and teach you and try to unlearn all of what you've already been taught about that. You know, that's really not an important area of academic inquiry. You know, my people suffered too. And so having to battle this, and so when I get up and I speak, maybe you all can edit this out because I know that this is going to be, is going to go on a website. But I know how to speak when I get up in front of an audience. I know the things that I need to say and that I can't be on my soapbox as a black woman. I have to be very scientific, and so I give the evidence. And I'm a very good scientist, and I know how to do that. But if I were giving the same information to the Southwest Berkeley Community Forum, I would say it very differently. And when I go to them and I show them all this stuff, they say, well, why'd you have to do a study to figure that out? You could have just came and talked to me. Right? Because the people know they're living it every day. But these are not only the real-life experiences of the people, the communities that we work with when we're engaging in our science, but it's our everyday realities too, right? But we have to be able to step outside of that and really engage in rigorous, as objective as possible science as we can. And that's why we have science. That's why we have the norms of science to kind of discipline our biases, because we all come to the work that we do with inherent biases. But that's why we engage in the scientific method, so that we're careful about those things. Yes.
And this goes back to when you're talking about focusing on the environment versus the individual. And a lot of times we know as public health professionals, the environment means more than a building. Mm-hmm. But a lot of times when people see someone in a neighborhood or see a population at a bad school, they tear down that school, they tear down that neighborhood and simply transplant them. And we know the risk that is involved in that and the stereotypes that are perpetuated when those ventures fail. I wanted to know your thoughts around that and how that could be prevented from people just classifying environment to a building.
Yeah, that's a good question. And so the first thing that came to my mind when you were talking was gentrification. That's happening all over our country, and what happens with gentrification is not that we fix communities up so that the people who had already been living there can come back and enjoy better spaces and more healthy spaces, but they are taken out of their communities and often are prevented from coming back in because it's not affordable anymore. The laundromat that was down the street is now a cupcake shop, and I don't want a cupcake. I want the laundromat. Or I want to talk to Mr. So-and-so at the corner store, right? Social relationships are important. And so I do think that there is more and more work in public health that's doing more than studying what, and not to say that this isn't important, because studying the built environment is important, and the built environment isn't about more than just buildings, but it's about street lights and speed bumps and parks and the way that we use our space. But outside of the way that we use our space is the way that people come together and the kind of social community that's generated in these spaces. One of the phenomena that we see with gentrification is, and many people are probably familiar with this, is a suburbanization of poverty. Because our spaces get reclaimed in inner cities where that didn't used to be desirable property, right? When redlining was happening, it was kind of white flight, right? Went to the suburbs. Businesses fled the environment, and we ended up having concentrations of urban poverty in inner cities. But now what we see with gentrification is that cities are changing, landscapes are changing, social communities are changing, and then these urban centers are more desirable for people to come and move in. So we're seeing kind of more shifts around economic and business investment and development in inner cities. Now, racial minorities and other lower income groups can't remain there, and they go out to the suburbs, and then we're seeing this kind of shift in racial composition and housing stock and all of these things. And one of the ways that this happens is through, or one of the factors that I think, one of the interventions that I think is trying to counteract some of this is the use of major transportation hubs as ways to maintain mixed communities, so new communities, but also communities that used to be in areas. So we build around transportation hubs, right? This is happening a lot in the Bay Area, where we put in and we revitalize these kind of, say, BART stations or metro stations or whatever your transportation station is here, and then we build stores and community kind of resources, health promoting resources around those. We develop mixed income housing as a way to try to prevent the kind of the exclusion of lower income groups from staying in those communities. So my point is that I think that we recognize that this phenomenon is taking place and that there are some kinds of interventions that are not predominantly coming from the public health community, but that are trying to inform efforts to kind of create that social space. So in the neighborhood that I live in now, the Fruitvale district of Oakland, we saw a major kind of one of these efforts around the Fruitvale train station. And when you talk to neighbors about what happened what happened to their social community when that happened, they talk about how they've still enjoyed kind of the social support systems that they have, and they were really worried about what was going to happen when this revitalization took place. But when they talk about the revitalization of that community, they're not talking about the buildings and the train. They're talking about still being able to talk to Mr. So-and-so and still being able to go to this person or that person. And so the social community is a huge aspect of this. If we look at, some of you may be familiar with the Moving to Opportunity study. Anyone familiar? Okay, so the Moving to Opportunity study was a randomized control trial that was conducted in order to kind of look at what happens when you move people into presumably healthier spaces. And so they gave low-income housing residents vouchers to be able to go and move into non-low-income housing, but they had to change neighborhoods. So the assumption was that by changing the resources around them, the buildings and the spaces, that their health was going to improve. And certainly some health outcomes did improve, but what we also saw was that people were taken away from their social communities. And so while some physical health outcomes improved, mental health outcomes got worse for some of these populations, and especially for Black boys. And when you ask them what happened, they no longer are around their social network, the things that really matter in their day-to-day lives, right? And it's not to say that resources, kind of physical resources, don't matter, but we can't kind of disconnect place from people, which I think is at the crux of what you're talking about. So it used to be in the public health literature that we wanted to separate what we call context and composition. What is the independent effect of place outside of people? But now we've come to see the light and realize it's not about separating, it's actually about understanding the way that people in place come together. So now we're using more relational perspectives to understand the importance of people in place. So I think we're kind of getting there, but I think that the work in that area, both the research but also the interventions to address it, are still in its infancy. The MTO, Moving to Opportunities. Mm-hmm. Okay, thank you. I don't know how to work that.
Thank you. Thank you very, very much. Thank you so much, Dr. Glover, for your tremendous work, your tremendous friendship. One of the reasons I told her I need not be introduced is because I want to thank Dr. Chandler for taking my speech this morning. Martin Luther King Jr.'s death was one that bothered me a great deal, as many of you may know. I think Dr. Kahn, told me that he listened this morning to an NPR interview that I did several days ago in preparation for the celebration of this assassination 50 years ago. And on the day that we passed the Affordable Care Act, many of you may recall that act passed near midnight. It was a Sunday. And of course, on that afternoon when I spoke to the House of Representatives in support of passing the bill, many of you may recall at the time I was the majority whip, and the majority whip's job is to count the votes, get to 218. And of course, there was a very contentious debate. And whether or not we would get to 218 was a question. for weeks. And on that afternoon, I spoke on the floor, and I recalled a event that occurred during the debate we were having within our caucus. One of the big issues is whether or not we would have something called a public option to rely upon as a stopgap or a safety valve when it comes to people who could not afford to pay for their health care. Well, one of my colleagues very contentiously said, we need to treat this bill the same way we treated the Civil Rights Act. And I was sitting there that day. Of course, it was a caucus discussion. I'm looking at people trying to figure out how to pick up this vote or that vote. Congressman John Lawson from Connecticut was chairing the meeting. He was chair of the caucus at the time. And I touched John on his elbow, and I said, please recognize me. And he did. I went to the mic that day, and I said, I want to ask my colleague, which Civil Rights Act are you talking about? And of course, she said the 1964 Civil Rights Act. I said, well, you know, when we passed the Civil Rights Act in 1964, it did not include voting. We didn't get the voting rights until 1965. When we passed the Civil Rights Act of 1964, it did not include housing. We did not get housing, fair housing, until 1968. And when we passed the Civil Rights Act of 1964, it did not outlaw employment discrimination in the public sector. It only outlawed employment discrimination in the private sector. We did not outlaw discrimination in the public sector until 1972. That's not which Civil Rights Act are you talking about? And I said, on that occasion that I've said many times since, and I was so pleased to hear you, Dr. Nuru-Jeter, say today, sometimes in order to treat people fairly, you have to treat them differently. I want you to remember that. In order to treat people fairly, you have to treat them differently. I, too, pretty despise the word equal. I have 3 daughters, one of whom is here, and I hope I don't embarrass her with this. My oldest daughter is 7 years older than Jennifer. And, of course, we were in business together one time. And we ran a weekly newspaper down in Charleston. And I it was all my money. So I gave out the orders. So it was periodically we would sit down and decide what the approach would be the next week. And she would tell me what her ideas were, and then I would tell her what needed to be done. I'd come on back to Columbia, of course, and she was putting out the newspaper. Paper come out the next week, and I looked. She had ignored everything that I said and had done exactly what she wanted to do. Didn't talk back to me at all. She's just been that way all of her life. Now, Jennifer, she's a doctor. We call her Dr. J. She has more degrees than the other 2 put together. But for some reason, Jennifer will call me all the time seeking my advice. Mignon doesn't pay any attention to what I say. Jennifer wants to seek my advice. And I would tell her often, don't ask me, go ask your husband. I gave you away. And she still, to this day, as recently as around 6 o'clock on yesterday, seeking my advice on dinner last night. I said, I'm out of town. Now, my youngest daughter is 4 years younger than Jennifer, Angela. She's my free spirit. Whatever happens is all right. The three of them, born in the same family, same mom and dad, as far as I know. They're different. They're different. So would I be fair to them if I treated them the same way? I don't think so. It doesn't mean that I love one any more than I love the other. It simply means that I try to treat them according to their needs. And that's the way to be fair to them. If I treat them equally, I will not treat them fairly. And that same principle should apply to society as a whole. I think that one of the most hurtful experiences I've had since being in the Congress has been Flint, Michigan. Flint, Michigan had the poisoning of an entire town, city, when people knew that the water could not withstand, or the pipes could not withstand the water. But they did it in order to save some money, irrespective of the threat that it had on their lives. Now, that was bad enough. But when I went to Flint, and I sat there listening to the community at large, really with tears, because I saw those little children, and I knew that they were poisoned for life. I knew from my meager studies that many of them would never fully develop because of the poison in their systems. And so I asked the question of some of the experts there. I said, let me ask you, you're telling me that this poison in their system is there. Is there any way for any corrective actions to be taken? They said, well, the best way is an overabundance of fruit. That's what they told me. Y'all are doctors. Y'all may know. I says, if that is true, why is it then that all of the calls going out for assistance are asking people to bring water? Why are we not asking people to bring fruit? Now, how many of you ever heard a call go out to bring fruit to Flint, Michigan? I never heard a single call. And so I wrote to some of my fraternity brothers, and I talked to the folks in the Divine Nine. Let's organize a fruit drive. Why? And this may surprise you, there is not a grocery store in Flint, Michigan. For all intents and purposes, the whole city is a food desert. After this, they started organizing fruit and vegetables on Saturdays, on street corners and all, but not the food store. Sometimes, in order to be fair to communities, we have to treat them differently. We have not been fair to Flint, Michigan, and those children, and we have not been fair to many communities throughout our state. I'll close with this. I was listening as Dr. Khan spoke, and I thought about how strong these elements in our society are, and I thought about the Confederate, so-called Confederate flag. The fact of the matter is, there is no such thing as the Confederate flag. There were scores of Confederate flags. The flag that flew on top of our State House for all those many years, went up there in 1962, was not the Confederate flag. It was the flag of the state of Tennessee. And when I wrote an op-ed piece about it, I had to have police protection. All I did was say what the flag was. But because people had bought into the myth in such a strong way, they were willing to issue death threats not to talk about it. And many of you may recall that when the flag came down off the State House, and then they put what they said was the Confederate flag out in front of the State House, it was not the same flag. And even then, it was the flag they put out there was the flag of Northern Virginia. It was Robert E. Lee's flag, who he asked the people of Virginia to furl and put away, and the people of Virginia did. But the people of South Carolina decided to honor it when the people of Virginia rejected it. We buy into these myths, and we live by them, and they don't want anybody to contest them, irrespective of how true they are. Such is the myth of race. Thank you.
Thank you very much for coming. There are a lot of research posters out there, so please go around and look at them. I'm just now announcing the Best Poster Award. It is going to Jennifer Mendelbaum. Are you here, Jennifer?